Today I am going to present one of the patients that we face in our clinical practice. It's a 17 years old boy, referred from Professor ا.د.محمد, an eminent professor of surgery in Egypt. And upon presentation is presented by bilateral severe pain in both your legs, cannot walk, on a wheelchair, and even he goes to the bathroom by the help of his parents. The pain was of three types: nociceptive pain, idiopathic as well as ischemic pain. The neuropathic from injuries of the different nerves, the nociceptive component from the injuries of the tissues, and the ischemic pain from the peripheral ischemic. On clinical examination, the right foot saw a gangrenous finger, second finger, and on the left foot a dorsal gangrenous patch on the dorsal of the foot. Okay, and when we did for him an arteriogram, when we do for him an arteriogram, it is can be classified as a non-reconstructible peripheral ischemia of the lower limb. As you see, there is no dysparanoff in his both lower limbs. When he presented to us with the itch, he's diagnosed as vasculitis, probably vasculitis. He's on a big list of drugs: steroids, vasodilators, antiplatelets, aspirin, Clexane, non-steroidal, anti-neuropathic pain as well as tramadol, and still he is in severe pain. He did, before he came to our center, a transcutaneous thermal frequency sympathectomy with one of the eminent pain physicians. With no response and pain is not minimized. So the question that in our brain, how we can handle this patient. So we have one free option. The first one is to repeat sympathectomy, because we had problem with sympathetic blockade is the abnormal anatomical variations about the position, the size, and even the location of the ganglia. But we carry the risk that we have to stop anticoagulation and we can increase the area of gangrenous patch. The second, to use a non-invasive energetical therapy, and being non-invasive, we are with such technique. The third technique to use the most expensive technique, the spinal cord stimulator. We are in a poor country and we have minimal experience of that. For these reasons, we selected to use cap energy, non-invasive therapy. Why we are using such technology? If we go to literature, we will find a Cochrane study about the use of lumbar sympathetic blockade in non-reconstructible peripheral arterial disease. Another paper about the use of radiofrequency posterior ganglia for acute digital ischemia, which mimic our case but in the upper limb. So what about the non-invasive technology? It's a machine, a non-invasive machine. It's called C200 because we have two channels. It can deliver about 620 watts of energy to the patient. It is an active plate as well as a passive plate. A radio frequency current. The cap energy has a lot of plates: a vaginal probe, rectal probe, external urethral probe, as well as a dental probe. The energy comes from the active probe. It's about 1 million cycles per second, heating the passive probe, returning to the active probe. This continuous bombardment of the tissues will create two important things: internal heating of the tissues as well as electromagnetic heat. This heat can be adjusted by the doctor to increase the efficiency. Here we are adjusted to 37 at the red light shows, and the temperature reaches only 30 as blue light shows, so we need more time. And this temperature again can be controlled by the patient, by the machine, by the doctor, all will increase the safety for the patient. The benefits, if you go to the literature, radio frequency increase vascularization, tissue surface, increase oxygenation, nutrition, increase regeneration capacity, as well as improving the function. On the cellular level, it will open a voltage gates of calcium channel, leading to production of oxyreactive substances, free radicals, as well as nitric oxide, which is a potent vasodilator. On the extracellular level, it will lead to production of three important things: the collagen by the fibroblasts, new blood vessels, as well as regeneration of the muscles. So we believe working on bone, muscle, ligaments, and tendons and fat will improve the nociceptive component of pain. Working with the nerve producing neuromodulators will improve the neuropathic component vasodilation and improve skin. Our target was to minimize and avoid pain and minimize the area of amputation in such child. The first session was on January 22. The last session was last week on 28th of August. The number of sessions, as I believe, was twice per week. Then after that, it became once per week. These are 36 sessions in red. The duration of sessions in minute, the type of the machine, and the leading of the machine. So if you are using one machine, it's called C200, so we can do two things at the same time and delivering only 600 watts, but if you are using two machines, so I can do 4 things at the same time, and we are delivering about 240 joules. After the 6 sessions, our expectation for the patient, especially in this case, we are looking for a complete pain-free state, no amputation, and better functional state. What's our target? We work on the lumbar sympathetic chain in the abdomen. Fortunately enough, the sympathetic chain and ganglia on the anterior aspect of the lumbar vertebrae. So putting the probe on the anterior aspect of the abdomen, it will face
next.
It will face the lumbar sympathetic chain. Again, it will solve the problem of anatomical variability in position and location, because nowadays we are using thermal frequency. And one of our causes of failure is invasive RF is anatomical variation. The second target is using it on the femoral triangle. If you use it at 37 degrees, we are working on the nerves, we are modulating the nerves and working on the peripheral sympathetic fibers affecting the femoral vessels. And if you work at 41 degrees, we are working with the vessels, vasodilating the arteries and veins, vasodilating lymphatics, as well as producing new vessels. If you are working with the capacitive and resistive probes on the normal tissue, very close from the ischemic area, will really help in the regeneration of tissues, and this will lead to formation of new tissues. And the last position is the drainage position, where we put the active plates of the soul and the passive on the back of the patient. This will remove excess fluid within the cells or outside the cells and pushing them intravascularly, improving the function of the cell. So this is the patient after 36 sessions, complete disappearance of the ischemic breach on the dorsum of the left foot, spontaneous separation of the right finger, and the patient is extremely intelligent. He's telling us, please continue, I am improving, don't stop our sessions. So we still doing more sessions aiming to, because the patient is still on medication, we would like to stop analgesics, we would like to reverse the pathology, and even we are hoping that we can get a normal arterial. So now expectations are more and more, we hope to stop all drugs and treat the diseases. So to conclude, this is a recent publication in August 22 about new medical method is electricity. So we are applying electrical current, electric frequency current. So this is the future in treatment. The second point we'd like to highlight that.
Next, please.
No, not next. The current therapy, which means transfer of energy, we are delivering energies to the tissues. Next. So it helps in pain relief, ischemic patient, restoration of tissue vitality, and even more. And previous one. If I'm in a vascular, next. If I'm in a vascular surgeon, I will start the current therapy with the patient first visit. I will add the current therapy to all my surgical modalities that I have, and before amputation, I should give a chance for the patient with the current therapy. Next. Finally, we have to work on more than one side. Here we work on the lumbar sympathetic chain, femoral vessels, femoral nerves, peripheral tissue enhancement, as well as drainage position. Next. I believe that combining the current therapy as well as unlocking therapy, which has been mentioned by Dr. Martin from UK, is a totally non-invasive techniques that are extremely helpful for our patient. So by the end of year 2022 and approaching 2023, I don't believe that any vascular surgery center is is present without the availability of both the CAR therapy and unloading therapy. And thank you very much.
Thank you very much. That was great. Let me ask all our guest speakers to come to the podium for the discussion. And for the online, Martin, I hope is still with us connected. So Professor Professor Graziani. And let me take the opportunity to have the first question by Professor Ahmed Ismail. Is Martin with us? Okay, so Martin is not connected. I'm sorry about this.
Yeah, I'm here.
Oh, okay. That's good. We have one question for you, Martin.
So Martin, good afternoon. Hello. Can I ask you about your cases when you consider the patient is having no option? Is he having low distal runoff vessel or repeated failed interventions, either endovascular or open, or no option due to bad general condition?
I suppose a mixture of a few of those, but generally it can be with a diabetic foot. It can be a no option because of the infection that's ensued within the foot. So it's in that particular case, it was a resistant Enterobacter, which was one of the main issues. He did have some crural disease, but it wasn't enough to suggest that he was having a major limb amputation at that point, quite imminently. But it sometimes boils down to what the patient wants as well. So when the patient's fed up and doesn't want any more intervention, or is fed up with looking at a chronic wound and thinks it's never going to heal, then sometimes the patient can turn around and say, just take the leg off. But we try to play advocate with the patient and try to pursue all options before we end up with that particular last thing, no option deal.
Okay, thank you very much.
Yeah.
We have a question from Dr. Ahmed Jamal, directed to Professor Graziani. It's a clinical question. He said, what type of wire do you use to cross plantar arch?
Because the intima or what remains of the intima in the tibial arteries and plantar artery is a roof, as demonstrated by Stoll. The most suitable is the stiff O14 coronary sites, polymeric at the distal segment, because it needs to be very slippery and very torqueable.
Yeah, I actually has experience, when you're using pedal arch, the wire must have a bend. So if the flexible end of the wire is less than 40 centimeters, for example, like nitrix, it is dangerous because it doesn't bend. But if you're using Pilot 200, Pilot 300, you go very well. I think this is what we taught Marco Menzi to use. This is used about 1,000 years to spine.
This is my technique.
Yeah, but I don't think not every point 014 wire is suitable for pedal arch. There's few of them because of the tough, stiff part of the wire, so it doesn't bend. Okay. So the other question related to Professor Peter Schneider, we know that you are the PI for Line Flow Company, and now we are hearing about on-shelf tools to do deep venous catheterization. In our country, quality of $50,000 is quite tough.
Yeah, no, I understand that, and I think I'm thinking about this whole area of exploration, and it's really new, and we don't really know where it's going to take us. I think, I'm gratified, I'm happy that there is one company that's dedicated to make this happen. So, but it's really limited what they can do, a small startup. So, and just by way of updating in the U.S., they have enrolled, but they promised 2 studies. It's fully enrolled now, just as of a couple weeks ago. And the 6-month data will be presented in the beginning of November. So this is terrific. And if this then becomes a part of the standard of care for those patients in the U.S., that will encourage others, I think, to then create new devices, new competing ways of doing the same thing. The off-the-shelf thing, I totally get it. Like you can take some Biobon and use an Outback, et cetera, et cetera. And I think there's a couple things. One is it's all of the competing covered stents we have are low radial outward force, so they need to be reinforced with plain stents. A second is that that you really do need a forward valvular tone, and that's really missing from the system. So you have to come up with some way to disrupt the valves.
Okay, that's a great question. We have a couple of minutes, so if there is any question from the floor, you just raise your hand, come to the mic. I will take the chance. We have done a few cases with the off-shelf devices for DBA, putting the snare arterial side, snare venous side, and putting the danger lead. I think this technique is actually quite common in Florida as well. Post-operatively, regarding wound care, what do you advise? Because it is totally different from revascularizations that we used to. You get this flushing venous congestion, a couple of days, a lot of discharge, a lot of pain. What do you advise us to do post-operative?
Well, a couple things. One is that increasing pain does not necessarily mean that there's a problem. I'd say about a third or more of the patients have an increase in their pain syndrome, and I think it may be related more to typically they have diabetic neuropathy that is stimulated now by the increase in perfusion. The second thing is that, everybody who does this now routinely has at least one sad story where the patient they treated that has a good hemodynamic result, but it's premature, and the patient says, oh, my foot is swollen, my foot hurts, I go to the emergency, and the first doctor that sees them doesn't understand. They did a bypass, your foot is purple, and they lose the leg. They get the amputation. So it's almost like the patient needs to have a bracelet, or they need a cell phone to call if there's a problem, so that they don't end up with a doc that doesn't understand what was done. And the last thing is, I think that the value of elevation is really helpful here. I think keeping the wound dry and elevating the leg for some period of time until that congestion improves. Makes it
diuretics?
Diuretic?
Diuretics?
No.
No.
No, not typically. You can't wrap the foot because you'll occlude the outflow veins. Yeah.
And we don't have the guidelines for post-operative care, I think. It hasn't reached the guideline or standardization of practice.
Yeah, we don't really have guidelines yet, but it's definitely different than every other kind of post-op that we take care of.
Professor Ahmad.
Before the era of vascular intervention, we were facing a patient with no option, foot ischemia. At that time, we were also doing venous arterialization but of course, based on the superficial veins, venous system, not the deep veins. So, is there any difference regarding actually at that time, the results were disappointing. I don't know why we should expect better results with the deep venous arterialization in vascular.
Yes, so this is a really good question. So, a couple things. One is, I do think that disrupting the valves is really important because if without disruption of the valves, at the first large tributary that the flow encounters, it will go right back to the heart, same as every other kind of AV fistula we deal with. And so the valve disruption is important, but beyond that, it's occluding the tributaries that contribute to draining the flow away. So, for example, many of these patients now either get, you can ligate the saphenous vein at the ankle if it's contributing to a large steel. You also can do coil-based embolization of the tributaries, the large perforators. And then I did get a chance also to visit Dr. Pramuk. I don't know if you know him, from Thailand, Pramook. And he now has made several presentations internationally. I got to visit him last month, and I got to understand what his practice is. And he's one guy that's gotten good results with the surgical, but he does an early angiogram afterward to do some of these fine tunings that you cannot do, I don't believe, can really be effectively done with open surgery, because you need a roadmap, a guide to see where is the flow going, how can you push more into the forefoot.
Okay, so let me take the last question to Professor Muhammad Abdul. We enjoyed your presentation very much, and you presented one of the most difficult cases that you could ever see. Do you have a pain clinic, or what do you advise us to direct these kind of pain management to?
First, I'd like to say that no option patient is a terminology that's extremely depressive to the patient and to the physician. So the use of non-reconstructive limb is a little bit much better from my point of view. And now I hope that these no option patients, we have new options, so there's no option patient. So we'd like to remove this from the literature. This is number one. Number two, to increase the success rate of our non-invasive or invasive therapy, most important that we as a pain physician, we have a endoscopy. We just see the pain, vasodilation, sympathetic nervous system. The vascularization has a panoramic view. So I always be in contact with the referral physician. So if we have more options to help the patients, we can. I have a pain clinic, I have a chronic pain clinic, and these patients are, with the introduction of non-invasive therapy, are extremely happy because we don't need to stop the anticoagulation therapy. While we're doing the invasive sympathetic blockade, we have to stop the anticoagulation with the risk of increasing the angular scale. And one of the problems with invasive is the anatomical variation of the number as well as cervical sympathetic chain. The site of the ganglia, the level is close to them. So these non-invasive techniques cover a bigger area to solve such problem. So I think it will open immediately. And I believe such machines should be present in any referral. Yes, it should be present because its use is very easy.
Thank you very much. With this answers the question. I would like to thank you all for sharing this 10th session with us. And as I've been instructed by Professor Ahmad Taha, we are eagerly waiting for you to come to the podium for the image of the Congress. It is 8K definition, which will become like 6 million gigabytes. So please come in. And to arrange it, I think we'll create a couple of rows. تفضل.